Thank you. As Nick said, I'm a trustee of the Patients Association, whose purpose in life is to ensure that everyone receives the health and care services that they need to live well. And nowadays that means we have to ensure that services are designed in partnership with patients. I'm also on the Digital Health Council of the Royal Society of Medicine, and their objective is to help people understand how digital technology contributes to patient-centred healthcare. The views expressed in this presentation are my personal views and are not endorsed by either of these organisations. I will give examples from the UK, but the lessons are the same wherever we look. Healthcare is designed for patients, not by them. Throughout my career, I've been involved in digital transformation across a range of different industries, and I've often jumped ahead of the adoption curve and been the person in an organisation pushing for adoption. I'm a passionate believer in the power of digital transformation, but management of IT development and pushing for change in organisations has presented many challenges. The issues that come up and obstacles to progress are strangely similar. So over time, my health has thrown me many challenges, and I have a lot of experience as a patient, both good and bad, both in the National Health Service and in the private sector. And these chronic conditions continue to be a problem, and nowadays we all, at my age, we're all doing the care coordination for our older relatives. So I'm helping coordinate care for my 92-year-old aunt and my 98-year-old father. I'm going to give you some examples from their experience. So in this talk, I'm going to talk about patient-enabled health records. I'm going to give examples of solutions used by myself and by patients and professionals. And I'll highlight some of the problems that I've encountered as a patient. I'll speak about patient-enabled healthcare records and my experience in North West London, and I'm going to focus on the Summary Care Record, which is a national project intended to share the most important information in a patient's health record. I then want to bring to your attention two technologies which show considerable potential to deliver change. I'm going to focus on England's National Health Service, but it may surprise attendees from other countries to learn that the issues that face us in digital transformation of health services are pretty much the same everywhere. The NHS in England is not a single entity. There are 227 NHS trusts that provide hospital, emergency, mental health and community care, and 7,000 GP practices who are responsible for primary care, and they also act as a gateway to the secondary care in trusts. And in addition, there are over 18,500 adult social care providers that sit totally outside of the NHS's accountability structure. Each of these organisations operates paper-based or many separate digital systems, and each is a separate legal entity, which has profound implications for data sharing amongst them. What I want as a patient is a single complete healthcare record that I can see and that is shared by all the healthcare providers that may treat me. But as we see, patient records are fragmented. Many organisations still use paper records or any number of separate digital systems. The NHS aspiration is to link these together regionally. There are already 14 such information exchanges, and the NHS long-term plan sets out that all regional exchanges should be in place by 2023, with some means of data exchange within and presumably also between them. The National Audit Office, whose remit is to examine public expenditure, recently reported on the NHS's state of readiness for digital transformation, and they found it lacking in several respects. In particular, this goal is more of an aspiration than a scoped and budgeted project, so in simple project management terms, it's not likely to happen. COVID has undoubtedly accelerated the use of digital healthcare systems of various kinds, but this type of project linking systems together needs many organisations to coordinate with one another, and clearly there hasn't been time for that. Furthermore, it needs patient involvement to ensure that the resulting systems are both usable and used. It's telling that in the report, although there are 79 mentions of the word patient, nowhere does it speak about this necessity for patient involvement in service design. So what does one of these regional information exchanges look like? Here's the patient portal for the Care Information Exchange, developed by the Imperial College Healthcare Trust for patients across North West London. It's actually my patient record, and we're viewing, or we would be viewing, the results of a couple of x-rays. Data flows from hospital systems across the region into this patient portal. I can get my test results directly, and in many instances I could also use it to communicate with my care team. Not only that, but if GPs subscribe to the service, then the patient can also see their primary care health record, and the GP practice will be able to directly access hospital appointments and test results and see reports emanating from the hospital care teams. Patients can also enter information from their fitness or healthcare devices and share them with their care team, and as we know, this will become a growing source of healthcare information in the future. So what's the catch? Well, uptake by hospitals and other institutions has been slow. I'm not dismayed by this, and I think the current pandemic will substantially accelerate adoption now some of the other barriers have been removed. So here you can see the adoption over time of the system. The North West London population is about 2.4 million, and the exchange currently holds records for over 1.6 million patients, but today it's used by only 66,000 of them. As you can see, the system is not confined to patients in North West London. The map on the left shows that they come from all over the UK, so those are that's where their primary care GPs would be located. This system, as I said, was set up by the Imperial College Healthcare Trust, and itself responsible for several hospitals in the region, and they have over 1 million outpatient contacts per annum. But even here, the fragmentation of healthcare is evident. Within hospitals, individual care teams need to sign up their patients, or patients need to sign up themselves. Many teams weren't aware of the system, but patients began to become aware of the system at the end of 2018, using the check-in kiosks in the outpatient departments. Only a fraction of the hospitals and teams within them are currently signed up, though. In the second quarter of 2020, there was a big mail shot to patients to get them to a list, and right now, as I say, we have 66,000 patients on the system. My GP practice holds a lot of my key medical information, and GPs have been reluctant to share their patient records with the system. Only 27 out of a total 400 GP practices have signed up, even though it's only a single click on their system console to enable it to push data to the exchange. GPs seem to have an irrational concern that it will create work for them. My practice, for example, is completely oblivious to the fact that I get my hospital test results at the same time as they do. So I and most of the other patients on the system do not get access to our records held by primary care. And of course, when I'm treated at hospitals outside of the region, I wouldn't get sight of my records there either. As I said, I think this may begin to change now due to COVID. Imperial College Healthcare Trust from last month required all of its staff to register on the system in order to receive their own COVID test results. And there's also a plan to provide testing to GP practices and other hospitals across the region, which would immediately make them aware of the service. So I think there's considerable hope. So let's look now at GP held records and how patients like me can access them. There are two major systems accounting for most of the GP practices in the UK, but whether to allow the patient's access is up to each practice. When you have access, you can do all of these things online. View your medical record, manage appointments, request repeat medication, message the healthcare service, and there's even an app for that. Recently, many have added online consultations, either in real time or delayed through the use of forms. And we can see that patients who can access their healthcare record are more active in their own care. And as we know from several studies using the patient activation measure, that activated patients have better outcomes. For example, between 40 to 60% of patients log into the Care Information Exchange every month, and over 30% of them respond weekly to a COVID survey that is currently running. Here's another shining example of activated patients accessing their own healthcare information. The My Diabetes My Way project across NHS Scotland has over 50,000 patients enrolled. 71% of them are active, and 70% of those who registered since 2010, when the service began, remain as active users. Patients using the online platform have better outcomes on all measures and are more motivated to make better use of consultations than other patients. Now I want to talk about the one part of the patient's healthcare record that is supposedly shared across the entire NHS in England. I single this out for mention here because it contains the most important information and is intended to be shared across all institutions, and especially for emergency care, when it might not be feasible to get information directly from the patient. The summary care record contains demographic information, information on allergies and adverse reactions to specific drugs. It also has a list of the patient's current and recent medication and their significant medical history, observations, treatment and investigation results. It records any special communication or support needs the patient has, for example, contacts such as the next of kin, and a patient's personal preferences intended, for example, for end-of-life care. And recently, COVID status has been added to that list. For some reason that still eludes me, you cannot access your summary care record online, and if you want to see or change it, you must speak to your GP. Now, despite all this, the summary care record is underutilised, and in several instances, this can adversely affect patient care. I want to give you some examples from a patient's perspective of this underutilisation of the summary care record. I have power of attorney for my 92-year-old aunt, and I'm registered with her GP as next of kin. I know this because I went there in person to register. Last year she had several falls. The ambulance crew phoned my 98-year-old father, who is disabled and has his own care problems, in the middle of the night. He tried to answer their questions, including giving them incorrect information in an attempt to be helpful. My aunt was admitted to hospital for a UTI, where confusion is a symptom. When I visited her, I discovered that my deceased mother was recorded as her next of kin with my father's phone number. This had come from A&E, who'd admitted her. I changed the next of kin contact in the ward and asked them to update the hospital record. This happened not once, but several times. I hadn't followed the NHS advice to speak to the GP if I wanted the summary care record updated, if that is indeed where the misinformation was coming from. Many patients complain about being asked the same questions over and over by different doctors. What the patient tells them is not necessarily reliable, as the next two examples will show. A caller to the Patients Association helpline gave us an example of where the summary care record was definitely correct but wasn't consulted. He was the carer for his wife, who has Alzheimer's, when she needed to be admitted to hospital. Staff asked his wife out of his earshot if she had any allergies. She said no. The summary care record listed an antibiotic allergy, but this wasn't checked. She was about to be given the antibiotic, but thankfully the husband intervened. He, like many others, called the helpline to ask what he could do to ensure that this doesn't happen to anyone else. Well, in 2019, my 98-year-old father was referred by his GP to the hospital's vascular clinic, who diagnosed very poor circulation in his legs. My father thought he was on long-term treatment with PPI for esophageal reflux, although it had been stopped over a year previously. I imagine that is why the vascular clinic thought it was safe to start him on blood thinners. Simply by consulting his summary care record, they would have known the true situation. 6 weeks later, he had symptoms of gastrointestinal bleeding. The GP directed him to A&E, and he was seen in the gastro clinic, who diagnosed esophageal ulceration. The blood thinners had caused his ulcers to bleed. They stopped his blood thinners, restarted his PPI, and wrote in a paper discharge note that the GP should inform the vascular team. That would have given them the opportunity to consider some alternative treatment. I don't think this communication happened, but in any case the GP updated his medication record, and the summary care record would have then shown that the blood thinner had been stopped. He was not referred back to the vascular clinic though, and several months later he began complaining of pains in his legs and feet that actually kept him awake most nights. The GP made a new referral to the vascular team, but this wasn't treated as urgent and he was told he would have a long wait. Meanwhile, the pains in his leg got worse, and eventually he was seen by the frailty nurse after he suffered a fall. She called the vascular team, who advised her that there was no urgency. This is inexplicable, except that their clinic record probably showed he was still on blood thinners, so they didn't suspect a blood clot. 1 week later, we managed to get him an emergency appointment with the vascular clinic, but it was too late. They found that the circulation in one leg was totally blocked by a blood clot, and 2 days later his leg was amputated. I'm not implying that the amputation could have necessarily been avoided, but the straightforward and direct sharing of information via the summary care record would have ensured that the teams involved would have had the correct information in front of them at the time that they were taking decisions. So it appears the summary care record is not being consulted. I had a look at the NHS dashboard and took a typical week in 2019. There were 2 million outpatient appointments, 325,000 hospital admissions, and 475,000 A&E attendances in that week alone, but only 163,000 summary care record lookups. That's less than 6% of the occasions when it could have been viewed. I asked around and I discovered that, yes, there's a lack of awareness, but it looks like if someone already has a hospital record, that will be consulted first, and it doesn't automatically pull in any data from the summary care record. So the reason people are already logged into their hospital system, and information governance adversely affects the usability of the summary care record. Healthcare practitioners need to insert their smart card and separately from their hospital system log into the summary care record, select their role, answer a challenge question, search for the patient, and then log that they've requested the patient's permission before they can view the record. It's just several steps too many for information that just ought to be there. I mentioned earlier that GPs have control over allowing patients to access their record online. Well, GPs also have control over whether the summary care record contains just the bare bones information of allergies and current medications, or whether in fact the additional information, for example on conditions and treatments, is included. However, on March the 20th, the Department of Health took extra powers to compel all of this information to be shared. On April the 23rd, NHS Digital simply switched on full summary care record sharing, effectively overriding individual GP surgeries settings. They also made it possible for any primary care clinic, or indeed for the 111 service, to view any patient's GP record using an NHS Digital service called GP Connect. This has made it possible for GP practices to flexibly collaborate during the pandemic and to provide extended hours services. NHS Digital made it clear, however, that these powers will only be used for the pandemic, and have to be renewed on the 30th of September. Well, I for one sincerely hope that this override will outlive the pandemic and that the awareness and habitual use of the summary care record will grow as a result. So what do patients think about healthcare record sharing? Well, most patients expect that healthcare workers treating them would have access to their record, and they are shocked when they discover that they don't. Most would happily share their data for research purposes, provided they're properly informed and consented. In fact, the more specific a researcher can be about the intended use, the more willing patients are to share. And most would also be happy to share data from their wearables or smartphone. And here's another use case where patients expect their data to be shared, but for information governance reasons it is not. It's usually not possible for ambulance crews to discover the fate of the patients they hand over to hospital care, where clearly it would be in everyone's best interest if they could discover whether their diagnosis and immediate treatment was correct, and in fact how the patient whose life they may have just saved went on to recover. I'm grateful to Matthew Snowshill of St Bart's for bringing his project, named Fem Feedback, to my attention. They've shown how beneficial this information sharing can be. The Patients Association recently carried out a survey of the patient experience, asking what is it like to be a patient. When they asked what single thing would have made your experience better, the responses highlight the importance of a single shared comprehensive healthcare record under the patient's control. So that's what patients want, but the reality is quite different. The patient is not in control and often has to repeat important information over and over. Data is not necessarily correct or up to date, or simply not available when needed, or visible to patients. And research opportunities are wasted because there are no easy ways of locating patients or advising them of the opportunities. It's also difficult for SMEs to develop clinical applications that can read or write to electronic healthcare records. So how will we bring about true digital transformation? Future healthcare systems will run on data, but this data will be even more prolific and its collection could become even more fragmented than today. So let's imagine a world that eliminates silos of information controlled by multiple intermediaries, where for each of us there was an up-to-date, verifiable, real-time record of every encounter we have ever had with a healthcare professional, where we could incorporate personal and lifestyle data, where the patient was ultimately in control of sharing this comprehensive record or aspects of it with researchers, where nevertheless clinical governance principles were followed, where SMEs could easily read or write to a patient's record with straightforward authorization, and where in the future artificial agents could browse the data and make inferences that would assist in clinical decision making or to help us to take proactive measures to maintain good health. All of this while maintaining our ultimate right to privacy. Imagine that an entire ecosystem of software apps can be developed, tested on real data, and commercialized in a lightweight regulatory regime. Patients would remain in control of who gets to use their data, but they or the National Health Service would be rewarded through a micropayment system when their data leads to successful commercial exploitation. Is this a pipe dream? Well, let me change gears and tell you about a technology that could help to bring this about. Distributed ledger technology, more familiarly known as blockchain, is the technology behind Bitcoin. This is a form of collective bookkeeping via the internet that enables multiple parties who do not necessarily trust one another to reach a single record of truth. Instead of an information exchange, illustrated here on the left as a central hub that needs to access multiple systems, the multiple systems together in a network maintain a single record of truth using irreversible cryptographic hashes. A complete patient record, such as the one I described earlier, is extremely suited to this kind of treatment. It is a series of sequential events which over time involve multiple organizations. Later events often depend on earlier ones. Each transaction would describe the addition of a resource to the official patient record by an authorized person, with the resource itself, i.e. the substance of the health record, stored externally. I won't elaborate any further here, but I refer you to the literature for more information. For example, if you look up the All-Party Parliamentary Group on Blockchain, you'll find several useful references. One of the other benefits of this technology is that it helps with establishing data provenance. Machine-generated data will be stored with information about the type of equipment used, its calibration status, and a precise timestamp. Patients' own devices would record information into the transaction log and would be clearly identifiable as such. Algorithms used to process the data would also leave their imprint in the record. As these algorithms become more critical to the implementation of medicine, with black box machine learning increasingly a feature of prediction and care, the ability to review and manage the supply chain of care data for a whole population becomes important. Otherwise, if an error is found in an algorithm used to make a diagnosis, how would you backtrack in order to identify everyone affected? Ahead of the availability of a vaccine against COVID, several countries, including those in the UK, are considering immunity or antibody certificates. These electronic or paper documents would certify your antibody status, i.e. that you've been tested and found to have antibodies. And the Centre for Data Ethics recently published a briefing note which drew a lot of attention. Both the Open University and the Alan Turing Institute have initiatives to develop these certificates in a privacy-preserving way, and there are several other initiatives around the world. The Alan Turing Institute solution can be app or paper-based, whereas the Open University's is purely online. It uses blockchain for privacy, and Tim Berners-Lee's decentralized personal data platform. This is now being pursued by BT with the Royal Pharmaceutical Society and 2 technology companies. But on a note of caution, I also recommend that you take a look at these articles from Harvard Medical School and the Harvard Berkman Institute for Internet and Society. The authors maintain that restricting movement on the basis of biology threatens freedom, fairness, and public health. And the other technology I wanted to draw your attention to was augmented reality. The patient experience survey that the Patients Association undertook also told us, unsurprisingly, that being a patient is scary and frustrating. And for COVID patients, the experience of being cared for by a team of healthcare workers in full or partial PPE is especially frightening. So here is a technology to help with that. The Imperial College Healthcare Trust used the Microsoft HoloLens, which is a computer worn on your head, which projects an image in front of you. And this has led to a fall in the amount of time staff need to spend in high-risk areas of up to 83%, and also just puts one professional in PPE in front of the patient, and the rest can be in the safety of an office environment, but can still take part in the consultation. It's significantly reducing the amount of PPE being used, as only the doctor wearing the headset has to dress up. Early estimates show that it's saving the Imperial College Trust 700 items of PPE per ward per week. So that completes the substance of my presentation. I've talked about the fragmentation of healthcare services, with communication gaps between service providers that are all too apparent to patients, but perhaps not so clear to service providers. Many different teams are often involved in a single care pathway, and patients often experience several different care pathways in parallel. Somehow these disparate organisations need to maintain a single record of truth. I've talked about patients' expectations of data sharing and how the reality falls very far short of this. In the future, data will become even more prolific, especially with the increasing availability of wearable and consumer devices and with genomics and metabonomics. And rather than stifling its use by information governance, we need to find ways to make it more accessible to data-driven algorithms, but in a privacy-preserving way. And I've discussed briefly how distributed ledger technology may come to be used in the data supply chain. So perhaps it's time to think not just about the technology, but also to examine the social contract regarding the sharing and use of personal data. I've talked about the power and underutilization of patient portals and the importance of the activated patient. And I talked about how the pandemic has increased the uptake of some of these digital-first technologies, but that this has happened at the single organisational care team level and not at the systems level needed for true digital transformation. And my final and perhaps most important point is that systems need to be designed with patients and healthcare professionals, not for them. This is something that everyone talks about, but very few accomplish. Well, the patient experience report I mentioned earlier is about to be published by the Patients Association, and they've also undertaken a survey of patients' experience of services under lockdown, and you should be able to find those on the website. If anyone is interested in following up this work, please get in touch, and especially if you wish to explore how to involve patients in your own research, you can email me at this address.